All right, everyone. So we are going to talk about lung nodule characterization and nodule management, and I have no relevant disclosures for today. So I wanted to just sort of talk to you guys about the objectives for the next 30 minutes or so so we're going to start with talking about different types of nodules. So there's the solid, subsolid, pure ground glass, and cystic or cavitary nodules. Then we're going to talk about PET-CT and the role of PET-CT, or what I consider the limited role of PET-CT in the evaluation of pulmonary nodules. And then lastly, we're going to discuss nodules, whether it's an incidental nodule or if it's a lung cancer screening and their management parameters. So a pulmonary nodules, we know, is a focal rounded or an irregular opacity, which may be well or poorly defined, measuring less than 30 millimeters, right? So that's the definition. And it's surrounded by aerated lung. And this definition used by guidelines has been included in contact with pleura, but also excludes those that are associated with lymphadenopathy or pleural disease. So when we think about different types of nodules, you can think about it in these four big categories. And then we're going to take some time to talk about potential internal contents of the nodule to help sort of define it even further. So when we look at the internal contents of a pulmonary nodule, if it has calcifications, you can think about the differential diagnosis as being granulomas, maybe it's a hamartoma, chondroma, or a carcinoid tumor. Now, carcinoid tumors can be divided into two groups dependent on the location. So they can be bronchial carcinoid tumors, which are these central lesions, and that's the most common type of carcinoid tumor. Peripheral pulmonary carcinoid tumors are much less common, and the calcification seen in carcinoid tumors is actually not that very common. It's about less than 10 to 12% of carcinoid tumors will actually have calcification, but it may be present. So that should be on your differential diagnosis for that. When you look at fat content of a nodule, it could be something like a lipoid pneumonia or a hamartoma. Other things to consider, if it has fluid within the nodule itself, you can think about it being an abscess or a mucocele. So let's review a few cases just to show you guys an example of different internal contents and what the differential diagnosis could look like for that. So here is a right lower lobe nodule. You can see it's nice and well smoothly marginated here. There's internal both calcifications and fat within this nodule itself. And so this is a case of a abnormal collection of normal cells of a slow-growing neoplasm called a pulmonary hamartoma. And it's the most common benign tumor, and so it's much more common to be a single lesion than multiple lesions. And most contain cartilage, which calcifies, and will also have bronchial epithelium. It can contain fat, like in our case here, and it's usually peripheral nodule, but it can also occur within the central airways, like I described. So about 20% of these pulmonary hamartomas will have FDG avidity associated with it, and fat is diagnostic if it's present, but it's sometimes difficult to differentiate it from necrosis. Other things that, as I mentioned, as far as calcification, it can be very large, as in this case that I have here in the left lower lobe here, but that's seen in only 10% of nodules that are less than 2 centimeters or so. And that popcorn calcification is pathognomonic for a pulmonary hamartoma. Next, we have another case of a pulmonary hamartoma, but this time it's in the airway. So this time it is a smoothly marginated mass in the left mainstem bronchus. You can see that within the mass itself, there is some low attenuation, and it has no polypoid features and no invasion. So when we think about endobronchial or airway nodules, it's actually a very uncommon finding in the lung cancer screening population. So about less than 1% of lung cancer screening cases in one of the largest trials, looking at about 50,000 patients, had an airway nodule. And the majority of endobronchial nodules resolved on repeat imaging, and most of these had no malignancies identified. But Nelson trial looked at the data, and about 22% of cancers missed at initial screening presented as central endobronchial lesions, meaning that we need to still look at the airways. And this is the path of multiple fat-containing cells within this endobronchial hamartoma of this left mainstem bronchus. So let's look at another nodule and look at the internal contents and see what this one may be. So this left lower lobe nodule is very low in attenuation. If you put a Hounsfield unit on it, it was less than 100 Hounsfield units. So this is a case of a patient who has lipoid pneumonia, which occurs due to accidental or intentional aspiration of different types of oils like vegetable oils, mineral oil, petroleum jelly, or other fatty material. It can also occur with endogenous lipids, like in some cases, say the body has issues with metabolic disorders, and they can accumulate fat within the lung itself. And characteristically, what you want to look for in these areas to call it lipoid pneumonia, you really want to have a low attenuation. So less than 100 Hounsfield unit, reflecting the fat content of this lesion. But sometimes you'll get something like negative 40, negative 30. And so that is something that you want to still follow up on, but it has to definitely be, a negative. You want it to be a negative 100 if you can. Other imaging findings for lipoid pneumonia includes consolidation, which may have a predilection for dependent portions of the lung. And another imaging finding includes crazy paving pattern if it's parenchymal finding of lipoid pneumonia. So here's a different case of another nodule, but the internal contents of this is different. This looks like it can be an area of focal bronchial atresia. And so you have an airway in the left lower lobe where you have mucus plugging in the left lower lobe here. And what's happening in the atretic portion of the lung is you have air trapping. And then if you look at it here, you're getting ventilation through collateral supply for this patient for as where the lung volume is coming from. So this is a case of bronchial atresia with mucus in the airway and then having an abnormal lung parenchymal finding related to that pulmonary nodule. So we've talked about different internal contents of a pulmonary nodule. Let's talk about what a subsolid nodule is and the category of that. So ground glass nodules, what are they? So ground glass nodules are nodules in which essentially you can make out the vessel within the nodule itself. And a a part solid nodule is when you have a component of both a solid as well as a ground glass nodule component of this nodule itself. And so this is a category of a subsolid nodule. And so when you look at pulmonary nodules, how frequent are they when you're looking at the lung cancer screening population, right? So those are our highest risk patients. And, about 20 to 40% of patients on their lung cancer screening CTs will have ground glass nodules. And those ground glass nodules have a wide differential diagnosis, and which we'll talk about that, but includes anything like an infection to malignancy. So here's a case of a patient who presented with a purely ground glass nodule in the left lower lobe here. And you can see that a PET CT was ordered for this patient 1 month later with no FDG avidity associated with this nodule. However, 2 months later, the patient did have a follow-up chest CT scan. And you can see that there has been now interval development of a solid component within the center of this previously completely ground glass nodule with now also spiculation and pleural tagging. So now this nodule is obviously very suspicious and it needs to be followed up frequently. So how do we manage pulmonary nodules it's kind of sort of like an art a little bit. And so first question is this a screening nodule or is this an incidental nodule? And so based on that, you will have different management parameters, which I'll end my talk with. But you want to see if the patient had any prior imaging to see if there's any growth within the nodule. And is there now a development of a solid component if it was a ground glass nodule, which in our case just was? You also want to evaluate the patient for other things, like what is the age of this patient? Are we talking about a 32-year-old healthy female patient, or is this a 72-year-old smoker? So your comorbidities are very important. And then are there more than one nodule? Is this multiple or is it a single nodule that you're evaluating? And then once you have answered all those questions, the thing that you really want to look at is you want to look at that pulmonary nodule and really look at it on thin section images and look for suspicious imaging features. Is there spiculation? Is there any signs of tenting of the fissures if it's right by the fissure? And when a nodule starts to develop air bronchogram, that is on the spectrum to becoming a malignant nodule. And that is something that you really need to be on the lookout for. And those are all things that you need to look on the thin section images. So we know that in 2015, the WHO had a change in the terminology for adenocarcinoma, with pre-invasive lesions being the atypical adenomatous hyperplasia, AAH, or adenocarcinoma in situ, or AIS, which was formerly known as BAC. So minimally invasive adenocarcinoma, MIA, invasive adenocarcinoma, and invasive mucinous adenocarcinoma is formerly known as mucinous BAC. And I want to review some of these cases and show you guys some path associated with how these sort of nodules look. So atypical adenomatous hyperplasia is a focal lesion usually located within the periphery of the lung. It's usually a small lesion, usually less than a half a centimeter or so, and the borders are irregular but well demarcated from the adjacent parenchyma. And these nodules, if you look at it on the axial, coronal versus sagittal reformatted images, they essentially look the same. The dimensions are very similar. And these lesions grow very slowly. So we're talking about something around 800 days for a doubling time. And so to determine the appropriate follow-up of these patients, you have to think about the benefits and risk of annual CT or having a biannual CT or what that may be because of how slowly these things declare themselves. Now, the Japanese Society recommends biopsy of nodules, anything like this, greater than 10 millimeters. And if it's less than 10 millimeters, they usually reevaluate at 6-month follow-up to look for increase in size or density of a nodule. And if there is an creation of an air bronchogram within this purely ground glass nodule, the odds ratio of that becoming an adenocarcinoma is 16-1. So you're looking for those suspicious features that I started my talk with. So here is another ground glass nodule in the patient's left lower lobe, and this was a case of atypical adenomatous hyperplasia. So many ground glass nodules remain the same size for many years. However, the larger the lesion it is, it's most likely to grow. And that was like the case that I showed you of that left lower lobe ground glass nodule that measured 27 millimeters. So that's pretty sizable. And it started as purely ground glass, but it developed a solid component. And obviously now that requires a different type of management for that nodule. Now, in addition, other things that you want to look for, a male patient, if they are at an older age or a prior history of any lung cancer, obviously increases the likelihood of that lesion progression as well. Now, ground glass nodules are more common in the never smoker, and these make up about 60% of those opacities that are seen on lung cancer screening CTs. But those are, when you're looking for the development of a solid component or any of those speculation features, sort of help drive you as far as your pretest probability of this being a malignant versus a benign lesion. So here's a case of an adenocarcinoma in situ that's presenting as a subsolid nodule. So you have a solid component here essentially with a pure ground glass nodule surrounding it. And this is a pure lipidic growth with no invasion. And the survival of these patients is very good. So they have a 100% 5-year survival rate, which is not something that you hear about as it relates to lung cancer, right? So this is a pre-invasive lesion. And so these patients have these irregular shapes and they could be multifocal. And so you want to look out for those patients with a history of smoking. They have sometimes increased density, and that is a cellular and fibrous response that's occurring in this patient. And obviously, as I mentioned, the dilated airway is also another suspicious feature to look out for. So now let's look at the problem. What are minimally invasive adenocarcinoma? As I mentioned, the first two cases were pre-invasive lesions, and now we're talking about minimally invasive adenocarcinoma. So how do you define minimal invasion? So that's a sort of a controversial area, particularly for our pathologists. So as I sit down with them and we discuss cases like this, the literature suggests that these patients also have an excellent prognosis, like the case that I just showed you. So they have a 100% 5-year survival similar to AIS. And what you're looking for in these patients is invasion less than 5 millimeter was an independent prognostic factor as significant as, say, vascular invasion or local regional lymph node metastasis. And it's actually been argued that it's the size of the fibrotic invasive focus that's more important than the overall size of these nodules. And these minimally invasive adenocarcinomas can present as purely ground glass nodules or solid nodules, but they usually are part solid nodules. So what I wanted to show you guys is one patient's chest CT, and this patient had actually 4 different nodules and the progression of these 4 different nodules. So let's start with the first nodule in the patient's left lower lobe. And this nodule is a pure ground glass nodule, and on biopsy, it was path proven to be atypical adenomatous hyperplasia with mild to moderate atypia demonstrating lipidic growth here. Here in the second nodule, you can see that in over a course of 2 years, what started off as a pure ground glass nodule has actually increased in size. And on biopsy, this showed airspace enlargement and fibrosis. And so this was a case of adenocarcinoma in situ. The third nodule that this patient had same size. So the patient's size is a pure ground glass nodule here, stable in size. But what you notice is that in 2 years, it actually slightly increases in density of this patient's nodule. And this was biopsy proven to be invasive adenocarcinoma. And then the last nodule that this patient had, this poor patient, 4 nodules, and all of these had, diagnosis associated with it, is 2 years. What you have is a growing solid component and density of this nodule. And this was a case of minimal invasive adenocarcinoma. And on biopsy, you can see that the solid component showed invasion and diagnosis as minimally invasive adenocarcinoma. So 4 nodules with 4 different diagnoses. And it's important to recognize that us as radiologists, we're not making a tissue diagnosis, right? So all of us, we're not saying that this ground glass, I think it's going to be AAH or, some infectious or inflammatory nodule. What you're looking for are those suspicious features that you will prompt you to have further management of those nodules. So these nodules, particularly those that are ground glass nodules, as they, progress, it's essentially a random set of events, and these are unpredictable, making them very, very hard to follow up and to also find out what is the appropriate time lapse between you follow up these nodules, and also for how long do you follow them up. Some people say 2 years, some people say 5 years, and is the answer really indefinitely? So that's something that I will pose to you guys at the end of my talk. So we've talked about the first 3 types of nodules. Let's talk about briefly cystic nodules. Well, we know that I'm not going to spend the next 15 minutes talking about the different cystic lung diseases because that's an entire lecture on its own. But there are several different causes of cystic nodules within the patient's chest CT, and you just have to look at that differential diagnosis, and it's all based on where are those nodules and the patient's age and other comorbidities that also associated with that patient. So let me show you a case of a patient's right lower lobe cystic nodule here. So there's a cyst here, and over the course of 3 years, you can see that this nodule along the surface of this cyst is increasing in size and density as well as spiculation. So obviously in the course between here, in 3 years, this is highly suspicious. And this is an atypical pulmonary cyst, and about 4% of lung cancers were associated with cyst at baseline. And this was followed by a reanalysis of that Nelson trial, which looked at about 22% of overlooked lung cancers on their initial CT scan presented as cystic disease, reaffirming that atypical pulmonary cyst is something that we should be looking out for in our patients undergoing chest CTs. Though the number is low, we know that about 1% of all cancers present as an atypical cyst, with about 5% of those being malignant. And the incidence of lung cancer associated with atypical pulmonary cyst is over low, with I would say if you look at different trials, essentially the number is somewhere between 1 to 2% of newly diagnosed lung cancers is associated with a cyst. Here is another 2 different patients with atypical pulmonary cysts that were path proven to be adenocarcinoma. And so when you look at some features of these nodules, what are the things that you need to be worried about as far as a cyst that you need to, just follow up annually, or is this a cyst that you need to have a follow-up for in 3 months or 6 months from now? So those are things for looking for this shape. So you want to look for a non-uniform shape, or ones that have associated nodular component, or a unilocular cyst, or abnormal wall thickening, or irregular margins. And over time, imaging demonstrated nodule growth. If you have a follow-up and if you see an increase in growth in size or an increase in wall thickening or enlargement of the cystic component, or transformation into a completely solid nodule or mass as seen here, those are obviously all very suspicious features for this nodule being a malignant nodule rather than a simple benign cyst. The other thing is that multilocular cysts have a higher probability of malignancy and are reported to account for about 20% of cystic lung cancers. And so given that LungRADS 2022 actually has a classification scheme and management of these atypical pulmonary cysts that I will briefly discuss with you. So what is the role of PET-CT in evaluating pulmonary nodules? Before I get to that, I want to just talk to you about, briefly speaking, is that prediction models that exist. And what these are different sort of composite models that have been published looking at different centers, nodules, and trying to come up with what are the independent predictors for determining whether a nodule is suspicious or not, and how likely is it going to be a malignant nodule. So if you look at the Mayo clinical models, they looked at essentially 419 nodules, and that was about 23% of those nodules were malignant. And the features that they looked at were essentially age, smoking status, history of cancer, nodule diameter, spiculation, and upper lobe location are signs that this, could be a malignant nodule. The VA nodule model included 375 patients. Multiple centers were included in this model here, and about 54% of the nodules that they found were actually malignant. And the independent predictors were smoking history, age, diameter, and the shorter time since quitting smoking. And then the Brock model was looking at about 1,871 patients undergoing lung cancer low-dose screening CTs, and about 5.5% of those patients had malignant nodules, and very similar to the other two models. So the age mattered, the gender mattered, family history of lung cancer, the emphysema and the degree of emphysema present, the nodule size, and also, again, upper lobe predominance was another thing that they took into consideration. And so those are all sort of things that you want to look for probability of malignancy when evaluating a pulmonary nodule. So when you look at PET-CT and the evaluation of lung nodule, the largest trial done by Gould and his group, that this technique showed a sensitivity of about 97% and a specificity of 78% for lung cancer. But there are several pitfalls associated with using PET-CT in evaluating lung nodules, particularly in the BAC, which usually manifests as ground glass nodules, as I just showed you, and they could be falsely negative on PET, but still be a malignant nodule. So you have to, order these PETs and interpret these PETs, knowing all that sort of clinical information as well. So as far as different radiology society recommendations for PET-CT and evaluating nodules, so for lung cancer ACR guidelines, PET-CT is suggested for any category 4 suspicious nodules when you have a solid component that's greater than or equal to 8 millimeters. Similarly, Fleischner Society has recommendations for incidental pulmonary nodules that if you have a solid component that's 8 millimeters or more, or if you have a part solid nodule, the solid component has to be more than 8 millimeters or more for the evaluation of PET-CT and determining whether you are suspicious or not for these nodules. So lastly, for the next 8 minutes or so, we're going to talk about different nodule guidelines and management of these patients. So let's talk about the lung cancer screening population. So we know that the lung cancer screening trial, the two big trials that essentially helped determine that patients get low-dose chest CTs and evaluating for lung cancer screening essentially was from the NLST data, so the National Lung Cancer Screening Trial, as well as the Nelson trial. So the NLST was a very large trial. So about 53,454 patients were included in this trial. And the rate of death from lung cancer was reduced by 20% in those patients that underwent low-dose chest CT versus those that went chest x-rays for detecting suspicious nodules. And if you look at that 20% data and you look at what the reduction in cancer-associated deaths is with mammograms, about 5% is the number for mammograms. And with low-dose chest CT, that number is reduced by 20%. So this obviously showed a huge dramatic impact on using low-dose chest CT for evaluating lung cancer in high-risk patients, in which we'll talk about what are those high-risk patients. In the Nelson trial, it included 15,792 patients. It was a slightly different patient population, looking at those who smoked slightly less. And the 10-year follow-up mark, the Nelson trial also found a significant reduction in death from lung cancer in those associated with lung cancer screening CT. They also included volume analysis. And so they compared essentially low-dose CT versus no screening at all. Okay, so now that we've talked about the lung cancer screening different trials, what I want to talk about is essentially since then, the USPSTF service task force criteria for those who can undergo lung cancer screening CT has gone through 2 iterations. So right now, it is recommended that a patient between the ages of 50 and 80 can undergo lung cancer screening if they have a smoking history of 20 pack years or more, or have quit within the past 15 years. And LungRads have gone through 2 different iterations. So the most recent is LungRads 2022, and they have different follow-up recommendations as far as, so since a patient, say, has their first lung cancer screening CT, now they're coming in for a follow-up, how do you manage those findings? They also have a specific finding section for atypical cyst and endobronchial nodules. So let's talk about those. So the LungRads ACR 2022 can be found on the ACR's website. It's very easily accessible. I don't expect anyone to memorize this, unless obviously you're a chest radiologist and you do 100 of these in a day. But essentially, when I look at the LungRads 2022 criteria, I essentially break it down into LungRads 0 through 2. So those I essentially consider as negative CTs, meaning that these patients are going to get a 12-month follow-up. So LungRad 0 is an incomplete scan. So say that they somehow accidentally cut off the lung apice. So essentially that patient needs to come back in for that scan. Or you think, this has findings related to inflammatory infectious disease and they need to come in for a follow-up. And so that would be a LungRads 0. LungRads 1 is essentially no nodules, or they have nodules that are completely benign in features, like some of the ones that I started my presentation with, like say it has fat containing or popcorn calcifications. Those are essentially negative scans of LungRads 1. And a LungRads 2 is a benign CT finding. So these are nodules. So you're looking at a solid nodule less than 6 millimeter, a part solid nodule with a less than 6 millimeter at baseline, or a ground glass is something 30 millimeters or less. So less than 30 millimeters is the ground glass nodules that would be deemed as being benign nodules. And we're going to talk about airway nodules separately. And juxtapleural nodules actually is 10 millimeters or less. So these are something that obviously you can come back to when you're evaluating nodules in particular. And anything that it's a LungRads 3 and above are ones that warrant a further follow-up that essentially is either a 6-month follow-up if it's a LungRads 3 category. A 4A can be a low-dose CT in 3 months, or a PET CT if that solid component is more than 8 millimeters. And 4B, it's a very suspicious, so either the patient's going to undergo multi-D conference for tissue sampling, or if it has a solid component that's greater than 8, you can get a PET CT on those patients. The other thing that I want to just briefly talk about is the S factor. That's for significant findings, whether you want to say that's a coronary artery calcium score that you think is going to be super high, whether the patient has osteoporosis or the patient has compression fractures. All of those things can be used on your S for the management of those patients. So atypical pulmonary cyst, as I mentioned, has a way of being categorized within the LungRads classification. And so the most suspicious of the atypical pulmonary cyst is a thick-walled cyst with growing nodularity wall thickness, or a growing multilocular cyst, or a multilocular cyst with increased loculation or opacities. So that would be a LungRads 4B. A LungRads 4A is a thick-walled cyst or a multilocular cyst at baseline, or a thin or thick-walled cyst that becomes multilocular. And as you go further down, they have less and less suspicious feature as far as management of these nodules. Now, endobronchial nodules also has a different category as far as nodule management of these nodules. So the more proximal the nodule is, the more that you're worried about it. So If you see a nodule that persists, an endobronchial nodule that persists on follow-up imaging, that it becomes a long-RADS 4B, and then you can decide whether it goes to bronchoscopy or how you want to manage that nodule. And obviously, if it has presence of air, then you think it's mucus, or if it's in the subsegmental airways, those are things that are benign, and so you think of that as being lung-RADS 2. The last thing is the step management. So say a patient undergoes a lung cancer screening CT, and so you deem that the patient is a lung RADS 3 at baseline. So the patient comes back in for a 6-month follow-up scan. And so the 6 month they come back and you see that the lung nodule is unchanged or smaller than before. When do you follow this up? Because essentially now this becomes a lung RADS 2, right? So a lung RADS 2 means that the 12-month follow-up, it's 12 months from the time of the most current exam and not from the time of their initial CT. Okay, lastly, Fleischner Society is a recommendation for nodule follow-up in those that were detected incidentally. So the Fleischner Society had guidelines starting in 2005 and 2013, and the differences between that and the most newest version in 2017 is essentially a higher threshold for triggering the need for radiographic follow-up and a greater flexibility in selecting a follow-up interval depending on the nodule morphology and patient preference, and a longer duration of radiographic surveillance for suspicious of subsolid nodules, okay? And so if you look at what Fleischner Society recommendations are, it's divided into solid nodules or subsolid nodules, a single nodule or multiple nodules, and then you look at whether it's less than 6 mm, if it's between 6 and 8, or greater than 8 mm, and that helps you as far as management of these patients. Key to uses of Fleischner is that the age is very, very important. So at 35 years of age, because the incidence of, you wanted this patient to be above the age of 35, because the incidence of lung cancer in those younger than 35 is very low. And those patients who have no history of smoking or any history of any other cancers. Okay, well, thank you all for your attention, and I will send it over to the next speaker.